Greenwood, who's the Vice President of Education and Research, and if I may ask all the morning speakers to come to the front for this session. Thank you.
I'd just like to start by thanking the experts this morning who've given some really insightful understanding of the background behind some of these clinical guidelines and then also some of the recent clinical trials that we've just heard about from the previous two speakers. I think the talks were extremely insightful, probing and interesting to the cardiology community. But like all of these events, it's now up to us, the audience and myself, to help direct the Jeremy Paxman type probing of these experts so that we can really get into some of the nuances behind some of these recommendations. And I think I'd like to go back to what Azfar said about the guidelines being written for 80% of the patients, 80% of the time. And as you and I all know, those are the really fairly straightforward ones, and it's the challenging and difficult ones which the guidelines never help us with when it comes to our day-to-day practice. And I think what's even more concerning perhaps to us as a community is the fact that of the guidelines that we see written, that at least 50% of the recommendations are generally based on either consensus or just opinion. And that really tells me that we need to be working much, much harder to do well-conducted and robust clinical trials in many of these disease areas to be able to answer much of the uncertainty that we have that still underpins our clinical practice on a day-to-day basis. So I think whilst we've achieved a lot, there's a huge amount more that needs to be done. And it's a difficult session. We've got sort of 40, 45 minutes, something like that, across a really diverse range of subjects. And I think what we're going to have to try and do is sort of break it down and get as much interaction from you, the audience, as possible, perhaps with a little bit of guidance myself. And I'm really pleased to see that we've got at least a couple of interventionists on the panel today. So we can have some fun, I think, talking to start with about the new STEMI guidelines, because, as you know, this is an area of acute medicine that's rapidly evolving with evidence base. And as a practicing interventionist myself, up in the middle of the night, I'm frequently rung up with conundrums about what to do with individual patients. And now I'd like to particularly sort of ask, I guess, Stefan, first of all, about the lowering of the thresholds for the patients to come to the cath lab. You and I, we all work in busy STEMI centres, heart attack centres, but now the guidelines seem to suggest that we should be bringing all types of bundle branch block, not just left bundle branch block, perhaps those with anterior ST depression, those with ventricular pacing systems. So all of those need to be coming in addition to the classic STEMI patient with chest pain and ST elevation. What's your opinion about that and the sort of evidence that underpinned that recommendation?
Yeah, thank you. That's a great question. I'd like to comment first that the reason that we include this in the guidelines is not to relieve the workload for us, but because we think it's good for the patients. We believe that we are missing patients who are actually suffering from acute myocardial infarction with some atypical presentations that we are on a regular basis seeing. At least I see patients on a regular basis that come to our cath labs a couple of days or a week too late. We see that they have presented with typical symptoms. They didn't have clear-cut ST elevations, but they did in fact have ST changes at the time of presentations. And they were interpreted as non-ST elevation chest pain patients. And eventually it became obvious that they actually had a presentation of acute closure of a coronary artery. And the only time point we can really help these patients at the time point of, early after the closure of that vessel. And therefore, we want to be more inclusive. But we clearly say in the document that we say that you need to, evaluate the patient. You need to take a history, look at the patient, as not only a telephone call or an EKG by itself. You need to review the history, the risk factors for MI, the appearance of the patient, as well as the EKG, to make that decision. And if there are EKG changes and a history compliant with or proposing a high likelihood of being a myocardial infarction, we want them to be immediately evaluated with an invasive angiography. So it will perhaps increase the workload, but we hope that this will actually increase the number and proportion of patients who are actually suffering from myocardial infarction. Okay. Because we're missing non-STEMI patients, and some of them have shock, some of them will get help.
Okay. And as far as a practicing interventionist, I mean, do you think the guidelines were a missed opportunity then, or perhaps we didn't hear about them specifically, but talking about the out-of-hospital VFRS cases, because clearly there is a large workload burden around this part of the acute presentation, and there didn't seem to be any specific recommendations in what you presented to bring that group of patients, which I would guess are ultimately the most at risk and the most life-threatened.
Yeah. Yes, I think that's because the data with the out-of-hospital VFRS is still in the process of being condensed, as it were, for us to allow us to know which patients benefit. And I think in the next year, the year after, as more and more data is presented, I think we will have clearer guidelines as to which patients benefit and which patients we should be taking. But in respect to your overall question, I have no problems with the guidelines. I think the guidelines lead. The problem is with resource. And typically the guidelines have to be out there, a consensus guideline with the experts, and then resource has to follow. If you look at the history of primary PCI in this country, it was exactly that. We had the guidelines first and then resources followed. And the problem is, if you add in all of these nuances that Stefan has talked of with the current resource that we currently have in this country, then I think you have a problem.
Okay. And I guess it follows on really to talk about cardiogenic shock as well, which again seems to be one of the most pressing and sort of life-threatening parts of the sort of pathway, which weren't particularly sort of... Yep.
No, sorry.
Sorry, were you asking a question? No. Okay. So just tell us about the sort of the way that the guidelines interpret, and perhaps Stefan, tell us about how they handle cardiogenic shock, because there's been some quite new evidence that's been quite exciting earlier on this year presented at ACC.
Yes, so we actually we give a recommendation that now in retrospect after the new the TCT, I was considering the TCT.
Sorry. Yeah.
The TCT news. We say in the document that patients who are presenting after cardiac arrest, if they have ST elevations on their EKG, they should be, of course, brought to the cath lab. We say also that in patients who have a cardiac arrest but do not present with ST elevation, we're more unsure about how to handle those. If they have a history of coronary disease or a high likelihood of acute myocardial infarction, we say that you should probably bring them to the cath lab also immediately. If they don't present with chest pain or a history of myocardial infarction and no ST elevation, we're more conservative. And so we say that we don't have any evidence, and trials are ongoing. But in that case, we say you should probably bring them to save the brain and give other medical therapies, and then reevaluate the need for acute cath. For patients with shock, we say that, also without evidence, we said that shock patients should probably be brought to the cath lab and probably be treated with multivessel PCI. In retrospect, after the TCT meeting, we learned that in a randomized trial, actually looking at patients with shock and multivessel disease, doing more than the culprit lesion was not beneficial. It actually increased the risk of death and renal failure. So in retrospect, we were mistaken. I need to admit, but we clearly say that in that recommendation, we say we don't have evidence. There are no trials. We just make a good guess, expert opinion, and now we have evidence, which is good. And now we can say the evidence is speaking in the opposite direction.
So is there a plan for the ESC to have perhaps an online addendum or sort of correction like the ACC did after the culprit trial, not culprit shock, the original culprit trial was published in multivessel primary PCI?
We have discussed this thoroughly after the TCT meeting and with the European Heart Journal and the Guideline Committee, and since we cannot say that we made a mistake because we made an evaluation as good as we could at the moment, but we will write a paper in the European Heart Journal to say now we have evidence, now we know more, and there will be an update in the next version of the guideline for myocardial revascularization that will be published in August. So there will not be an update, formal update to the guideline, but a paper discussing this.
Great. Okay, so I'd like to open this up to the floor. We've got somebody there who's very keen. And I think you feel free to sort of blend into the sort of dual antiplatelet therapy, particularly because this is all around acute coronary syndromes, ST elevation MI. So we can sort of move seamlessly into sort of Azfar's sort of domain as well, I guess, whilst we open it up to the floor.
Thank you, across London. Would you allow me, Chairman, to ask 3 burning questions of clinical relevance?
We'll start with one, and we'll see how long it takes to answer. There's a big audience.
Can I ask Professor Zaman about I have an issue with the duration of antiplatelets requirement in the moderate or the high-risk patient, as you nicely illustrated them on your slides. On what basis that duration was determined? You may have somebody who is classified as moderate risk and getting a stroke within a month, and you may have somebody who is on the high risk and going on for years without having any event.
So this was the graph of high bleeding risk and high ischemic risk. So that's a retrospective analysis of all of the data, looking at patients who were classified as high bleeding risk on the HAS-BLED score. And when they're followed retrospectively, if they have antiplatelet duration for the ACS of longer than 6 months, their bleeding risk overrides their reduction in ischemic risk. So it's based on retrospective data from the Paris group.
Thank you. Can I ask a question, Chairman?
Just to see if there's any more questions from the floor, first of all. Particularly in light of the STEMI guidelines, because Professor James has to go very shortly, so we might just want to sort of front-load this session a little bit with STEMI questions. Lady here?
Yeah, I have comments. When we first asked our primary PCI service, we didn't take left bundle branch block patients directly from the paramedics. And what we found, actually, was that almost all of them were not acute occlusions, and we were doing a lot of interventions on relatively frail patients. A lot of people had long-standing left bundles and did have complications, but probably not an acute occlusion. We reverted to then going to A&E where they would have a medical assessment, and then we would be called in if they felt that it was a STEMI presentation. How do you envisage that with these new guidelines? Do you suggest that these patients are going to come directly to the cath lab for assessment almost on the table, which is what we currently do with the STEMIs? Or do you envisage that they will still have another line of assessment within an ED where a medic will look at them, will look at their old ECGs, will take more detailed clinical assessment? I mean, I do understand that angiography is relatively low risk, but it's not zero risk, and there's also the risk of the patient being in the wrong place with another serious diagnosis.
Yeah, this is a very difficult clinical question, how to handle this in reality, and it relates both to left bundle branch and right bundle branch and pacemaker EKGs. When we don't have an opportunity to review the EKG properly, it's very challenging. And we've retrospectively looked at registries and observational data to see how accurate can we predict an acute coronary occlusion in those types of EKG, and it's very difficult. And so we have to rely on the assessment the best we can. And it's, of course, it's a little bit poorer from the EMS. It's a little bit better when the patient sees a doctor. Hopefully a little bit better if the patient sees a cardiologist. But we need to bring them to a PCI facility and somehow try to make that assessment as good as possible. In some cases, it may lead to that we are calling in the interventional full service doctors, nurses, and everything in vain, sort of. But there's no other way around it, really, to try to assess the patient as good as possible and try to evaluate if they have symptoms consistent with MI, acute MI. There's no real good way around it. We cannot wait for troponin elevations We cannot. You can do echocardiography, but you know the limitations of acute echo. So, unfortunately, that may be a negative result.
One more quick question on STEMI, and then I think we'll have to move on to the next sort of panel members.
Yeah. Going back to the VFRS patient and I suppose the cardiogenic shock patient, how strictly should we be adhering to the 120-minute target, particularly in the DGH? The reason I'm saying that is obviously the patients with VFRS and chest pain and ST elevation come to our hospital. By the time they're assessed, intubated, an anaesthetic team is sought, a bed with an ITU bed at the PCI centre is found, the clock is ticking. And within that time, you are considering in your head whether or not to give a thrombolytic agent rather than PCI. And I personally have had conversations with PCI centres who have said, you know, don't worry about the 2-hour target, get them across once there's a bed available. And you know you're sort of getting past that 2 hours. What's your feeling about that particular scenario?
Well, I agree completely. We didn't really form a line or a statement with respect to exactly that, but we agree, and I think we say something in the text that for shock patients, cardiac arrest patients, we're more liberal with the time, and we believe that primary PCI is better than fibrinolysis in most of the cases, despite the fact that it may go over 2 hours. It's difficult to state that in a clear statement saying exactly what to do. So we haven't done that, but we are more liberal with respect to time in those shock patients.
Okay, thank you. I think in the interest of time, we'll probably move on from the STEMI guidelines, and again, we'll thank Professor James if he has to sort of...
I need to run to the airport because I need to be back at 5 o'clock this afternoon. Thank you.
So, thank you very much for your contribution. And in particular, stepping in at very short notice for the valve guidelines. Okay, so we'll move on and we'll put Azfar in the spotlight a little bit. So I'm sure there's going to be a huge number of questions around dual antiplatelet therapy. It's a sort of perennial thorny problem, really. So I'll just start things off just as a little provocative statement, I guess. And you looked at some of the extended data with some of the guideline recommendations going out for 3 years, and you talked about this balance between bleeding and cardiovascular risk reduction. And I think the actual sort of nuance of the detail was that it was about a 0.5% relative risk reduction when you take into sort of net clinical benefit. And that seems a tiny, tiny amount of gain for what could be a hugely resource-consuming requirement to put them onto 3 years of, say, ticagrelor, monitoring in primary care, who's prescribing all that, the costs of the drug. Has there been any sort of underpinning evidence around the cost-effectiveness or health economics of this sort of strategy?
So not at the moment, but I'm told that in the new year, NICE will be looking at this extended therapy. But you talk about the minimal benefit, but you have to look at it, John, in the context of where we've come with cardiovascular risk reduction, both in the stable and acute setting. We have made huge achievements, and there's a fantastic BHF curve that shows the reduction in mortality and morbidity. So this is benefit on top of your standard secondary prevention therapy. So we're no longer in the realms of either mortality benefit or large benefit. We're looking at small incremental steps. And we're now looking at trials, in my opinion, that look beyond 1 year. Because out to 1 year, we do really well, from everything from diagnosis, interventional management, secondary prevention. So we're now looking beyond the 12 months at ongoing risk. So these are small incremental steps that shouldn't be sniffed at, but added to on top of what we're achieving at 12 months.
Right. And assuming that we can afford that as a nation.
So look, affordability is always going to be an issue, and all I would say is let NICE make that decision. We as clinicians shouldn't be making that decision unless asked to.
Okay, question from the floor. Yes.
With respect to dual antiplatelet, I think it was a recent study showing that you could probably discontinue the more potent drug like Prendergast and substitute Peripheral after a month.
So I thought you were going to mention the Prague 18 data, which was published a month ago. So the 1 month data is very clear. This data comes from patients who, because of bleeding, operations, emergency bleeding had to stop their dual antiplatelet therapy at a month. So that it's not trial data, it's in an emergency setting, and they found these registry data showed that in those patients where the dual antiplatelet therapy had to be stopped for an emergency reasons, these patients actually did okay afterwards. So that's where the 1 month data comes from. And if you have a patient who has emergency bleeding, requires hospitalization, and they've had 1 month, then don't put them back on. But you cannot use that data to recommend 1 month therapy.
I'm talking about this potential substitution of what's thought to be a potent agent by less potent agent.
So the Prague 18 data is the only most recent data that I'm aware of, where because of cost constraints, many patients in Prague 18 were switched from prasugrel and ticagrelor at 3 months to, and there was no increase in events. Correct. So the Prague 18 data is the first prospective data that I'm aware of, where inadvertent switching to 3 months showed no increase in events at 1 year.
And also, do you think, if you have a patient who needs anticoagulation, do you have a recommended dose of a direct DOAC to use in conjunction with either single or dual antiplatelet therapy?
Yeah, great question. So I can only refer you to the 2 trials that have been published, the Pioneer and the Redual PCI. So in Pioneer, they use this new dose of rivaroxaban, which was 15 milligrams, which... So the problem is not that it's not licensed. The problem is that in the stroke prevention studies, the dose used was 20 milligrams. So it's a dose that is unknown. Forget the license. We have no evidence for the 15 milligram in stroke prevention. If you then go to the Redual PCI study, they use the 2 doses that were used in the stroke prevention studies and shown to be effective. So you have the 150 milligram BD of dabigatran and the 110 milligram for the high bleeding risk. And if you have concerns about the rivaroxaban dose, for the reasons that you've stated, then dabigatran 150 milligram BD for the high ischemic risk and the 110 milligram BD for the high bleeding risk seems to be a good compromise.
Okay, one quick question on dual antiplatelet therapy at the front.
Coming to the end of your year, how comfortable are you about stopping all antiplatelets and just leaving them on antiplatelets?
Did everybody hear that? Sorry. Just quickly again with the microphone.
Coming to the end of the year, how comfortable are you with withdrawal of all antiplatelet drugs? And I think most of my colleagues are very uncomfortable.
That's a fantastic question. Look, cardiologists, interventional cardiologists, are wedded to antiplatelet therapy. All cardiologists are wedded to aspirin. Okay, the real answer to your question right now is that I'm not comfortable, if I'm honest with you, but as I said in my talk, that through 2018 we will be getting 2 studies, Global Leaders and Twilight, which hopefully should answer the aspirin conundrum about how important aspirin is in the face of these more potent antiplatelet agents. But having no antiplatelet agents after 1 year, had you asked me 2 years ago, I would have said not comfortable at all. If you're talking in the context of the newer drug-eluting stents, which we know with bioabsorbable polymers that they endothelialize typically after 3 months, but definitely after 6 months, I would say to you right now, more comfortable than I would have been last year. So yes, I'm happy with stopping the dual antiplatelet therapy with the modern 3rd-generation stents at 12 months.
Okay, great.
And just for the reason is so that you've lost the local need for the antiplatelet therapy, you're now into the systemic risk reduction, and Compass tells you, although with a much smaller dose, that there is some extended vascular protection. Yes, I would have to say that because the stent should have endothelialized. Now, within the new guidelines, the guidelines state this rule about complex PCI.
Keep it short. Come on.
Okay.
Keep it good. So the answer was yes, was it?
Yes.
Okay. Good. Okay. That's a really short one. Okay, I think we should move on a little bit because we've got still a couple of our experts here that don't feel challenged and in the spotlight yet. So I think we'll talk to Lucia Mazzolai. And and perhaps we'll talk about the peripheral arterial disease guidelines. So I'll just set the scene a little bit. And I think there was quite a provocative thing in the guidelines that you talked about, and this was the screening for everybody over the age of 65. And again, my question comes back to the practicalities and the resource implications that underpinned that recommendation. And is that really deliverable, not just in the cash-strapped UK, but also across the sort of the rest of the sort of developed the world as well?
Yeah, it's a very provocative proposition, and the problem with lower extremity disease is that it is really underdiagnosed already in those patients that are even symptomatic. So to have general physicians or cardiologists or angiologists to do it in asymptomatic, it's even more difficult. The thing is that we have a diagnostic tool that it's easy, and it's the ABI. It's totally underused, and that should be, it's cheap, reliable, and it's really reproducible. So this is something that should become common, custom to do it, even for general practitioners. The idea of the 65 is that people with lead, although asymptomatic, they have higher risk of cardiovascular events. And we know that these patients are badly treated. They do not have statin, they don't have lower blood pressures the way they should be. So the idea is to really educate people and doctors, and especially the general practitioner, to take care.
But I think you said the America trial, which was the screening trial, which was negative ultimately.
Yeah, it was negative, but those were patients that already had coronary artery disease. And in those patients, general screening did not add on the prognosis in the sense that...
So screening the highest risk didn't help?
Yes, exactly. It did not help.
Advocating now screening the lowest risk?
Yeah, those patients already have to be protected for cardiovascular events. Adding an ABI, it did not help. But the America's trial was a slow number trial. It's the only trial, so we also need to wait for other evidences.
Any questions from the floor on the peripheral? I'll spread it around a little bit, but go on then. No one else has got their hand up at the moment.
I think something that exercises a lot of cardiologists and cardiac surgeons. I think that exercises a lot of cardiologists and cardiac surgeons is the presence of carotid disease in people who are going to have CABG, and how you should revascularize it, how you should assess it, and so on. I mean, I've skim-read the guidelines. I couldn't see anything. Is there an expert consensus view on this?
In fact, no, because there is a lot of controversy associated when we had to revascularize the carotid artery disease. And indeed, what the guidelines really say is that the decision should be individualized in a multidisciplinary team, which means that we do not know when we say something like that. So it's really difficult to understand. Also because the strategy, whether it's stenting, whether it's a surgery, it's not devoid of any risk, and it's also the timing as compared to the coronary bypass. Is it better to do it before, after? There's really controversial data, so the guidelines do not really tell you what to do because there's no evidence.
Okay, thank you very much. I think we'll move over to John Deanfield, and we'll talk about PCSK9 inhibitors and the future for all of us. And I guess this again is a really sort of novel and very rapidly evolving area of cardiology at the moment, and the evidence base. But it sort of seems to me that now that we're moving into these sort of microRNAs and vaccinations, that actually we could be getting ourselves into a scenario whereby we say to the population, you can just do what the hell you like in terms of diet, eat as much as you like, be as fat as you like, because actually we'll just look after it with a little injection once or twice a year, something like that. Is that really the direction of travel? Do we think that the healthcare message is going to spell out for us?
Well, it's always the poison chalice question. And, if you want to do anything medical, you then assume that everyone is going to eat cream cakes and behave badly. I don't think that necessarily follows. If you go to an FH clinic, they're stick thin, they don't smoke, they get the message. So if we get the message across to the public, they don't behave in the way that you've just described necessarily. But obviously you're being provocative. But I do think we're not interested in medicalising the population unnecessarily. But we are interested in reducing cardiovascular risk in the population. And somehow we have to get a broad message across to the public at the same time as treating the high-risk people we identify to a level where we can really make a difference to their risk. And that's the challenge. So, a little advert for the JBS3 guidelines, they were all about lifetime risk management for future gain and persuading people that it's not waiting to get into these conversations that you've been having for the last 20 minutes. It's around never seeing your cardiologist by altering your behaviour early on, and we called it investing in your arteries as a concept, in the same way as you invest in your pension. Now, we have to persuade people that's worthwhile and might mean you never get one of these drugs or you never see your cardiologist. So that's really the challenge.
Great. Okay, question from the floor. I think there's somebody with a microphone here.
Yeah, can I just ask a fundamental question? Why is it that even after 40 years of this debate, we're still not sure whether people should get statins or not? Because every now and then you get an editorial in BMJ disputing it, and then Rory Collins and company rebutting it. Why can we not come to a conclusion or a decision based on evidence that this is a good thing to do?
Yeah, I have to say I'm puzzled by the same question. I just don't get it. I don't get the BMJ, I don't get the Daily Mail and some of these things. I think they're difficult. The problem is that the issue is actually not just a medical issue. It's really a societal issue as well. We're talking about potentially medicalising large chunks of the population, and everyone is intuitively uncomfortable. You've already heard John, provoking me with the previous question. It's exactly the same question. You don't want to medicalise people unnecessarily. However, the situation with statins has undoubtedly changed. In the 1990s, you saw the statement from the president of the British Cardiac Society at the time. There was genuine uncertainty. We've had 25 years of amazing research to show that lowering cholesterol improves your outcome, is safe, by and large, with a few side effects, and now costs almost nothing. A year's supply of atorvastatin 80 milligrams a day costs in the States less than $120. This is incredibly cheap medication. So we're not in any way in the sort of PCSK9 rationing concern thing. We've got pretty effective drugs, we know they're safe and they're cheap, and we give them to lots of people. And I don't really understand, like you don't, why this message is not being put out there properly to the public.
Okay, one more quick question from the middle then.
So I noticed you're still talking about LDL cholesterol as the main target in lowering, but I understand that non-HDL cholesterol might be a more accurate assessment of risk. And do you think future trials will use that and our guidelines will move towards that? And if so, why?
Yeah, it's a really good question. In the JBS3 guidelines, we talk about non-HDL cholesterol. It's better because you don't have to fast. It's better because it predicts the response to statins better, and it includes lipid subfractions that are going to be clearly shown in the next year or two to be related to cardiovascular risk. So we should be talking about non-HDL cholesterol. The literature is full of trials looking at LDL cholesterol, and that's why I showed you those data and talked about LDL, simply because we're in a transition phase to what would be a new recommendation. You're absolutely right.
Okay. We've got a couple of minutes left, and Brian is chomping at the bit. So whilst you think about your questions around PFO closure, I guess I would just like to ask the provocative starter for 10, which is the trials were highly selected patients, as you pointed out. I mean, multiple exclusions. What do you think the risk to the structural heart disease doctors and the interventional community is extrapolating those very rapidly into broad sort of appeal and broad practice, such that we get technology get creep across many patients who actually did not fulfil those trial entry criteria where the benefit has been shown in small numbers?
Thanks, John. That's always a wonderful question. I think there are a couple of points I'd like to make on that. First of all, that they were highly selective, and actually you can see from the number of patients that were closed outside of the trials, highly inappropriately selected, and it's very good evidence out there that a lot of the highest risk individuals were not included in the trials, and they were actually taken out of the trial because the conversation with the doctor went along something along the lines of, "Oh, I really don't like the look of this, we'll close your PFO, we won't put you in that silly trial." Whereas if they were in a more marginal situation, well, we don't really know what to do, I'll tell you what, we'll pop you in the trial. I think the main area in which applicability across a broader spectrum needs to be treated with caution is the issue of stroke versus TIA. And I very specifically did not bring up TIA at all in my talk. And the reason for that is TIA is a myriad of sins, anything from a bit of a funny turn to someone who's essentially had a stroke. It's just the symptoms didn't last for 24 hours. And you'll notice in the studies we were talking about, you either needed to have a firm neurological evidence of over 24 hours of symptoms, or alternatively you needed to have radiological evidence of stroke. And I think if we keep to that criteria, we'll avoid creep into a bunch of individuals who, for instance, have got migraine with neurological symptoms, which clearly, from a lot of evidence that I again didn't talk about, have got a very marginal benefit from PFO closure.
Okay. So one quick question from the floor. No, one in the middle, first up. Although you have asked a question before, was there somebody else who hasn't asked a question? Some chap at the back? Oh, there he is, yeah. Go on then. One quick one. Keep it short.
Dr. Clapp, I've got a 34-year-old lady who's a police officer who presented with a cryptogenic stroke and she's got a PFO by both bubble study and TOE. We have looked hard and we have not found any arrhythmia so far. What would be your recommendation? Just leave on antiplatelets or start on anticoagulation?
So if I understand that correctly, you have a 34-year-old who doesn't have a PFO, is that correct?
He has a PFO. She has a PFO.
She has a PFO.
Yeah.
You've excluded arrhythmias as best you can. I'm assuming you've looked for cerebrovascular disease, and you've looked for the recognised thrombophilias.
Yeah.
And I would close a PFO.
But there's no commissioning.
I would find someone who has a hospital that is able to continue despite the fact there is no commissioning.
Excellent, excellent. Well, I'd like to thank all of the panel members. It's been a really interesting session of sort of question and answers, and I think we do need to move on in interests of the keynote speaker now. And I would just like to say I'm looking forward to having my vaccination for cholesterol so that I can continue to enjoy my